Hello, welcome back to Adult Health 1. So we're working through into Unit 2 now. Mainly, we're going to talk a lot about the um, Chapter 46, diabetes, and then most of the rest of the Unit 2 is focused on uh, respiratory conditions, um, management of respiratory infections, and upper and lower diseases, upper and lower respiratory diseases. So that's the focus. But diabetes is a big role in this. So we'll spend a decent amount of time on this. So hope that you can view this lecture before class so that we can do more focused review and more focused on clearing up muddiest points and concepts. So we're talking about diabetes, or there's like a meme that used to go around, the diabetes, or as they call it in the South, I got the sugar. I heard that one a lot. So we're talking about diabetes. That's where we're moving at today. So what's happening here? So the main organ involved is the pancreas, part of your endocrine system. So the pancreas has these cells called the islets or islets. It's kind of how it said, islets of Langerhans. But these are where the hormones that are chiefly involved in the metabolism and the regulation of glucose are. So you have your beta and alpha. So you have your pancreas, and then the cells part of the islet of Langerhans are beta and alpha cells. Beta release insulin, which goal is to decrease blood sugar, and alpha cells release glucagon when blood sugar is increasing, or excuse me, when we want to increase blood sugar. So a lot of times, just as a rule of thumb, when I was teaching A&P, I used to always kind of tell people, most people have heard of insulin, think of it dropping blood glucose, decreasing blood sugar. Glucagon, I can always remember that. Like I used to joke that glucagon was like when glucose is gone, who do you call? You call glucagon, like it was a like it was a commercial or something, or like a superhero. So when my glucose is gone, again, it's not gone. When it's low, I call glucagon. So when glucose is gone, I call glucagon. Maybe that's helpful. Maybe not, but it seemed to always kind of fit for me. Thing with diabetes in general, too, as we're discussing this to start off, more than 29 million Americans have been diagnosed with diabetes. There's predictions that by 2050, that's one in every three adults will have some form of diabetes. Beta cells, again, release the insulin. The goal of insulin is to move glucose from blood into all the cells, and that's mostly targeting cells in muscle, liver, definitely a lot of fat cells. Fats are great storage cells. They store energy in the form of glucose. And insulin can be released in small doses, like micro doses, to help regulate this, all part of the homeostasis. So during fasting periods and we're not eating, our glucose will drop in the blood. And if needed, again, part of homeostatic balance, the glucagon gets released by the alpha cells, and they'll move glucose out of the cells back into blood. So what's kind of the mechanism of action that's happening? This is a nice image, but it kind of shows what insulin does. Insulin, if you imagine, is kind of like the key that unlocks a glucose channel. So pretty much every cell in your body, again, more specifically, definitely going to find this more in muscles, liver, cells, those kind of things. But typically, most cells will have a receptor for insulin. Insulin acts like a key that goes in the lock that is a receptor and opens up the closed channel that allows glucose to flow into the cell. And the cells will utilize it for energy, or they'll store it, that kind of thing, depending on the cells we're talking about. So, risk factors for diabetes. So, there are differences, type 1, type 2. You've got to know the difference between type 1 and type 2. So, we'll spend some time talking about that, but that's a need to know. You have to understand the difference between the two. But do keep in mind the principal problem with diabetes, diabetes mellitus, either way, the principal problem is always going to be, if you think diabetes, the principal problem is elevated blood glucose, which you guys know is called hyper for high glycemia, glucose in the blood. So that's the chief problem with diabetes mellitus. You got to kind of keep that in mind. Always keep that in mind that that's the chief issue. So type 1, we'll talk about it. It's an autoimmune condition. We'll talk a little bit more about it, but this is beta cells being actually attacked by our own antibodies. Typically, you're going to have a familial hereditary tendency towards this. So risk factors would be parents, siblings, and then less than 30 years old. This is quick onset, usually in childhood or adolescence, much earlier in life. And this has nothing to do with your weight, your diet necessarily. It's more hereditary linked and situational and those kind of risk factors. For type 2, there's plenty of risk factors. Metabolic syndrome, just poor diet with high carbohydrate and glycemic intake, sedentary lifestyle, usually older than 30 years old, obesity, overweight go hand in hand with diet. Ethnicity or race, different ethnic groups tend to have higher incidence of type 2 diabetes than others. Poor cholesterol control, so elevated triglycerides, low of the good cholesterol, HDL. There is more of a risk for really if gestational diabetes in pregnancy. So if your mother were to have gestational diabetes, there is a slight risk factor for more prone to develop diabetes as an adult, or if you're a rather large baby. PCOS, polycystic ovary disease, and then actually just lack of sleep too. But I think the lower levels of sleep, obesity, overweight, sedentary lifestyle, and glycemic control, those would all be modifiable risk factors, right? Things that could change, that you could change. Obviously, the ethnicity, gestational diabetes, or your size as a baby, or things that you couldn't change, non-modifiable risk factors for type 2. So let's talk about type 1. So again, genetic link, autoimmune, basically think type 1 diabetes. Again, chief problem with both types of diabetes is the same issue, elevated blood glucose levels. But there's basically no insulin secreted. The actual beta cells that secrete insulin have been destroyed by antibodies your body has created itself. So this is a small percentage of all diabetes, around 5% of adults right now with diabetes have type 1. Much more at risk for DKA, diabetic ketoacidosis, much higher risk in type 1 diabetes. And that's mainly because the homeostatic control is really out of balance without lacking beta cells. There's basically no beta cells, which means basically no insulin is secreted for the most part. They also call this, if it helps you remember, they also call this insulin dependent diabetes mellitus. So insulin, that's a really bad I, but insulin dependent diabetes mellitus, basically, meaning they're dependent on insulin to live. They can't make it efficiently to regulate their glucose levels. And that's diabetic ketoacidosis is the biggest risk factor for this, because it's mostly seen in type 1 because of the acidic ketone bodies that are formed from glucose. Obviously hyperglycemia, the ketosis, which is DK, is a form of metabolic acidosis. Going to have probably like feeling of confusion, nausea, vomiting, fruity breath, and Kussmaul respirations. Kussmaul respirations are your body's compensation mechanism for trying to correct acidosis. This is like a hyperventilation. Your body's like forcing you. Kussmaul respirations are. So that's kind of part of the DK process because your body's trying to compensate. And then they may have breath that smells like fruity, like the fruit gum or something like that because of the high sugar concentration. Also, you're going to see in that patient, you're going to see glucosuria. You're going to see glucose in the urine, mainly because, right, the body's trying to get rid of all this glucose. And so that's going to lead to osmotic diuresis. Talked about that before, the osmotic pressure. So the osmotic pressure kind of shifts and fluid will tend to follow solutes. And so fluid will follow sodium. It'll follow plasma proteins. It'll definitely follow glucose. So we're dropping excessive amounts of glucose that changes osmotic pressure to go from the glomeruli into the nephrons, and we'll lose excess fluid that way. And that could cause electrolyte loss and imbalances as well. So what's kind of happening in type 1 diabetes? Again, the pancreas does not produce insulin. The beta cells are being destroyed or have, been destroyed by our antibodies that we made for it on this autoimmune condition. So again, insulin is like the key that unlocks the glucose channel to cells. And normally insulin comes along and helps unlock that channel and allows glucose into the cell. But if not, there's no insulin, then the insulin receptor is just there with no key to open it, and the glucose channel stays closed, and glucose tends to accumulate in the blood, and it just can't get into the cell. That's what's happening in type 1. So symptoms of type 1 in adults and children, again, think early onset with type 1, think childhood or adolescence onset, typically before the age 30. Excessive thirst, excessive hunger, unexplained weight loss. That's usually due to the shift in like water weight. Probably going to have osmotic diuresis, and also some fat wasting as glucose kind of gets stored in different places. Blurred vision, that's due to high levels of glucose, cause glaucoma and vision changes. Slow healing, cuts or sores. You got to think with anything with diabetes, there can be slow healing of wounds. But if you saw that in a child, that would be really recognizable. General fatigue, vaginal yeast infection, frequent urination. So like really, really full diapers frequently in infants, bedwetting in children when it wasn't common before. And this slide on the right kind of gives an idea. Weight loss, fatigue, frequency of infections increases. Peak incidence is usually around 10 to 15 years old. That's the peak of we see incidents. And there's the 3Ps. So the 3Ps is like the trademark of hyperglycemia, the 3Ps here. So these are need. You gotta hear these ones. So this is not just type 1 diabetes, but all diabetes and hyperglycemia. These are the peak signs and symptoms of high blood sugar. Polyuria, polydyspnea, and polyphagia. So polyuria is all means like much or many. So polyuria is much urination. Polydyspnea is much thirst. I'm very thirsty. And polyphagia is I'm hungry. The reason someone's hungry too is that the glucose is utilized for energy and other factors in our cells, but it's not able to get into our cells when we have type 1 diabetes specifically too. So it's stuck floating in our bloodstream and not being utilized effectively. And therefore we're losing energy and our cells are kind of starving for metabolism. That's where the increased hunger comes from. So remember your 3Ps. This is kind of called the 3Ps of diagnosing diabetes, but it's definitely going to see more pronounced in like that 10 to 15-year-old range in children. You see all these things, you're going to think probably type 1 if we're in that age bracket. But the 3Ps go for any hyperglycemia. So the 3Ps also work for kind of identifying hyperglycemia in type 2 diabetes. So it's not the gold standard, excuse me, it's not the gold standard diagnosing diabetes, but you're going to see as far as symptoms go, the 3Ps is the like standard understanding of what hyperglycemia causes. And again, that polyuria is due to excess glucose getting pushed out in the kidneys. And the thirst too has to do with that and the fluid shifting. You're going to be peeing a lot. You're going to be losing fluid. You're going to be thirsty, and the drop in osmotic pressure. So insulin therapy, unfortunately, guys, for you forever and always throughout nursing school, insulin is going to be a need to know. And that means that this chart is going to be a baby for you for a while. This is going to be something you want to hold on to, because there'll be plenty of NCLEX questions about insulin stuff. You're going to have to have a general understanding of this chart. You're just going to have to. There's no kind of other way around it. So this is definitely need to know. So again, kind of keep that in mind. So things to kind of talk about. You can see on this chart, we have time course is basically kind of the naming nomenclature they use for some of these insulins because based on how long they have an effect or their peak effect, basically. But on so and then on the second column is agent. That's the names specifically of these different types of insulin. Then you have onset. Onset here is basically how best to onset is the when the action first starts, basically. So you can notice for rapid acting insulin, the onset is in pretty much 15 minutes for most, even up to 5 minutes for glucine, glulicine, excuse me, glulicine. Some of these names are challenging even for me. I'm more of a, I always find the trade names easier. That's why they come up with trade names, and I'll say those sometimes on accident. But yeah, but yeah, 5 minutes even. So quick. This is when the action of this insulin is first starting. Peak means the highest impact, basically. If you kind of look at it like a chart where onset, it's like nothing, and then onset, and then peak effect, and it's going to drop off. So that would be your peak, is when the peak effect of this medicine, when it starts, is onset. And then last over here is duration, is the total time between onset and when the action of the medication stops. You may know all this already, but this is pretty standard with a lot of medications. But it's just important to kind of note that too, that to make the point for insulin specifically, it really matters about. I'd say the biggest thing to know about insulin is definitely the peak. Well, really all of it, I guess, onset, peak, and duration. But probably peak and duration as the kind of most important. And so when that action stops and returns to baseline, we've had a duration. So that's very important with insulin therapy to kind of have a general idea of. And so you can see that the duration of some of these rapid acting is still in the neighborhood of 3 to 5 hours. Even though their peak effect most of the time is going to be within an hour, hour and a half, 2 hours. But this is so rapid acting is for rapid reduction in glucose levels. So those agents are Lispro, Aspart, like I said, glucosamine. The kind of standard one of the first insulins made is short acting down here. And this is just regular insulin. That's a good name for it, thankfully. Onset takes a little bit more time, 30 minutes to an hour. Peak around the same as rapid acting, slightly longer, more commonly 2 to 3 hours, and then 4 to 6 hour duration. So this is the reason that this is the reason for this one is that that's why this is commonly given before a meal, just because of its time period. So if I give this before a meal and someone starts eating, essentially the peak effect of what they've eaten and then digested is going to happen after kind of 60 minutes and sometime in this window. So the peak effect of insulin is going to be taking place probably during the highest time they have glucose levels, and that's kind of why. Some of the other kinds, intermediate, typically called NPH, neutral protamine hecadone. I just like to call that NPH because that's a weird one. But NPH is always kind of standard for the intermediate insulin in the middle, basically. Onset, slightly longer, more like an hour, hour and a half. Peak is much longer depending on the type of NPH we're talking about, but most of the time it's 4 to 12 hours. So I always kind of throw that somewhere in the middle of like maybe 8 hours. So if you kind of break these down in general, you're thinking rapid acting, like my kind of median peak is like an hour, short acting 2 hour peak, intermediate about 8 hour peak. Again, kind of giving yourself a best guess. And then the duration of intermediate can be up to 24 hours that it has an effect. And then again, it should be noted when someone's doing NPH that, like, if it's in the morning, they definitely shouldn't skip lunch because we're hitting into somewhere. They shouldn't skip a meal really because we're going to be hitting somewhere into peak effect around that time. So if they were to skip lunch, they took NPH, and it's possible that the peak effect will happen when they have a lacking of any extra sugar from their diet. Excuse me. So long acting is the last. Some of the examples of these are Glargine and Detamir, or Detamir. I always call these Lantus and Levemir because that's easier to say. Lantus and Levemir, these are the most common you're going to see. There are some other variations of them, but long acting, again, you can see kind of the difference. Levemir has kind of an unknown onset, or some of them have a little bit of an unknown onset. And what that means basically is that it's such a wide duration. And the way it works is much more, instead of like this mountaintop onset peak duration, the long acting insulins are much more of like a non-linear scale, much more of a kind of like status effect like this kind of scale. So it's very like gradual and then gradual tail off. And so the onset is maybe 3 to 6 hours, but it's a little bit more unknown directly. And it's kind of a continuous peak. And these are 24 hours for sure. 24-hour for sure. These are designed to be basal dosing. So like daily plus something else. A lot of times if someone has a lot of issues controlling their sugar. So that's your rundown on the insulins. Again, this chart, this concept, it's just need to know. It's not going anywhere. You're going to have to know this. Going to have to. This is a chart that kind of shows it. This is kind of hard to read, I think, sometimes, but if you're like a chart to kind of explain it, that kind of shows you. Endogenous is talking about someone that's non-diabetic. You can see that lines, that first line, orange line, very like rapid, like boom, peak, boom, controlled, where as far as like normal control of insulin, and then we don't or normal control of glucose. But if we don't have that, if we have diabetes, we don't have normal control. We have to counter it. And you can see like the long acting line, like I talked about, right? Much more like a whoosh, gradual basal kind of small low dose over a long period of time, where the others are much more of a peak and then drop off, peak and drop off kind of deal. So a little backstory or history about insulin, nothing that necessarily is test questions, but McElroy, Charles Bess, James Collip, these are the insulin. I mean, in the grand scheme of the world, medication in general is relatively new. I would say in the grand scheme of just world history, but the 1922 was the first time that they used this to treat high blood sugar levels. And he still suffered. This patient was still suffering from acidosis, so it didn't work. But again, I mean, before this, definitely there was less prevalence of type 2 diabetes. And when someone had type 1, it was mostly that at this time period. And that was usually a death sentence. There was no way to really fix that. We couldn't synthetically make insulin or extract insulin, but they've done different forms of insulin now where there's some synthetic versions of insulin like that long acting Lantus and Levemir, and there's other regular insulin. Can be human insulin, it can be porcine, which is pig derivative. Different variations we make now. So this is another need to know sliding scale. Mainly the need to know is just like, what is it? How do I use this? So hopefully you've heard of this before, you've seen this before, but for sliding scale insulin for treating diabetes, it's really basic. It's just follow the scale. You at least just need to understand what it is. This is a very common scale that varies per facility. So keep in mind, it can be difficult. It can be different. So this scale that we have here as an example is not like the universal scale, if that's what you're thinking. It's not something you need to memorize. It's just know what a sliding scale is what would be the point of this. And so this is much more common with type 2 diabetes as well for control, because typically they make insulin, they're just insulin resistant. over time because of their history or predisposition, genetic history. And so this is there to help like cover their meals and treat a waxing and waning blood glucose. And they still produce insulin enough that we may not have to give it, they may not need it as much. But type 1 diabetes doesn't always typically use a sliding scale because they get scheduled insulin usually because they have to have it to live. That's why they call it the insulin dependent diabetes type 1. And so again, basically the synopsis is, oh, if I just said, if I have a sliding scale and I work in a facility, if you just said, hey, your patient's blood sugar before breakfast was 255, all you'd have to do is go to the scale, see where 255 falls. It falls here, and then bring my eyes over here and look, and they are going to get 9 units of insulin, whatever insulin, I don't know, regular. They would have listed, it's probably short acting insulin, honestly, or maybe rapid acting. But so sorry, my computer is making noises. I don't know why it's doing that. It keeps distracting me. I have to figure that one out. So apologize if you guys can hear my computer, the Windows sound of stuff. I could probably fix that real quick. Anyway, sorry about that. So it means that, yeah, whatever the number falls in, I just pick that number of units based on this order. And then what this order does is allow all the options to, if they're low blood sugar, obviously we're not going to give them anything. We're going to, sometimes they usually have hypoglycemic, so low sugar protocols, which have like an order set that tells you to do this thing. If they can swallow in their weight, give them some carbs, or do this if they're low, and then call the doctor. If they're really high, like some scales go above 400 or some go above 500, you give this many units and then you go and contact the doctor. So it gives nurses presets to work with basically before contacting the doctor. This is used a lot to just in the hospital settings for sure. And again, just note that this varies among institution. Some institutions will have like in their formulary of orders or their order sets, they'll have 3 different scales. They'll have like a low dose scale, a medium, and a high dose scale. And that would be depending on the patient's history and how much insulin they use already at home and that sort of stuff. Like someone that takes an oral diabetic medication and doesn't take insulin at home, they might put on a low dose scale, that kind of thing. So all right. So again, this is just kind of giving an example. So if the example to understand sliding scale. So if the doctor orders 5 units plus sliding scale insulin to be administered ACHS, which if you haven't heard that abbreviation for, ACHS, AC means before meals. HS means hour of sleep. So this is a pretty typical frequency for insulin administration. It's saying before meals and at bedtime, basically. So usually like 10 p.m., depending on the facility you work at. So at 11:45, before lunch comes, the patient's blood sugar is 325. How many units of insulin will you administer this patient? Now, keep in mind, receive 5 units plus, and they can do this. So that sometimes they'll have insulin they're supposed to receive before every meal, plus fall in a sliding scale, plus, right? So, right. So if you said they're supposed to receive, I just blanked at 325. So you see that we're here. So we're going to get 12 plus 5. So we're going to give 17 units of insulin for this blood sugar before lunch. Maybe they snuck a cookie or something. You got to watch out for those. Maybe some diabetics can be a little sneaky. Okay, so hopefully that explains sliding scale. So the other half of this is oral anti-diabetic agents. There's a few different types. There's several different types, but this slide has some of the most common ones you're going to see. Guaninides, second gen, sulfon, I always have trouble with that one. Sulfonamides, Nilurias, sulfonylurias, and biguanonides. The most common of these three that you see here on the slide, but metformin uh, basically inhibits production of glucose by the liver. So our liver is usually, remember, our liver gets what's called the portal vein comes from the GI tract to the liver to process vitamins, process toxins. So our liver is usually the first one to see the glucose after it leaves our GI tract from digestion. So it goes to the liver either for storage or processing. The liver is a lot of responsible for processing and holding on to our glucose or creating it. And basically the goal is helps the liver synthesize fats and do other stuff. And metformin is trying to just basically inhibit the production of any more glucose from the liver, and that controls blood sugar. Glipizide, glyburide stimulate beta cells, secrete insulin, and they can sometimes use these in combinations with metformin. Sometimes it kind of depends. But the kind of metformin is also called glucophage, is its generic name. These guys can be used in combination. It kind of depends on the patient and their history and that sort of thing. So we've talked about type 1 diabetes. We've talked about treatments and insulin therapy. So now we have to kind of talk about, make sure and take a pit stop and talk about type 2 diabetes. This is the main one you're going to see in your practice because it affects 95% of all the people that have diabetes. Only type 1 is 5%. So, again, if you call type 1 insulin dependent diabetes, you would typically they call type 2 non-insulin dependent diabetes, but or call it insulin resistant diabetes. It's characterized by insulin resistance. Basically, there can be a combination with type 2 diabetes of cells being resistant to receiving like the key that is insulin to unlock the channels of glucose, that is insulin resistance. And then there can be some beta cell destruction or pancreas impairment to secretion of insulin, but it's not total destruction of beta cells by antibodies or something like that, like an autoimmune disease that is type 1. It's a more variable disease, usually seen in people older than 30. And people can have really mild symptoms, maybe take an oral anti-diabetic med and treat it that way, or even sometimes just changing diet and exercise can control type 2 diabetes, where you can't do that with type 1 because you're insulin dependent. You have to have insulin. So they can be mild. The 3Ps is a little bit less severe with these patients, but this is still a cardinal way of diagnosing it and figuring out someone has hyperglycemia. These patients are much more prone to chronic levels of high blood sugar and poor wound healing. A condition called acanthosis nigricans. We'll look at that in a second. But basically, overall, the problem on a pathophysiology side is the beta cells just cannot keep up with the increased demand of insulin, because they're going to keep producing insulin because it's like the body's like, the sugar is too high, and that makes the pancreas secrete more insulin, but the cells are just resistant to it. They're not receiving that key to unlock and open it up. So they're going to have the 3Ps: polyuria, dyspnea, polyphagia. They're going to have fatigue. The blurred vision, again, comes from the high sugar concentration and the sluggish blood flow in the eye. Frequent or slow healing wounds and infections, erectile dysfunction, pain, tingling in hands and feet, usually called paresthesia. That's typically kind of related with what most people consider diabetic neuropathy. Just has to do with the glucose and the interaction with the nerve endings, especially in the periphery. So acanthosis nigricans kind of looks like this. This is common with type 2 diabetes. Again, that's acanthosis nigricans. It's a condition that causes areas of dark, kind of thick, velvety, I guess would be the right word. Velvety is what I've seen used. Skin and like body folds and creases. So around the neck, armpits, maybe under the breast in women. groin, that kind of area. So a combination of obesities and type 2 insulin resistant diabetes lead to this development. So this is a nice little chart that kind of gives you the comparison of type 1 versus type 2. Again, the stuff in the middle is a Venn diagram. The stuff in the middle of the Venn diagram is consistent among both, right? Serious health problems, complications, healthy lifestyle, and medical supervision. And symptoms include the kind of three P's: thirst, increased urination, and maybe blurry vision. Those all are similar, but where they're different is type 1, you can't cure it, we can't prevent it. The body just doesn't make enough insulin. Beta cell destruction, causes are unknown, but it's technically an autoimmune condition and genetics plays a role, and they require insulin. Type 2 is it can be prevented or even corrected, technically, cured, quote unquote, through lifestyle and dietary modifications. The body can either not create enough insulin or develops insulin resistance, but it's usually a combination of the two. And there's a lot more factors, a lot of non-modifiable risk factors like genetics and aging that play a role, but also modifiable risk factors like inactivity, obesity, diet. It could require insulin, could require oral meds. Again, the theme for diabetes in general is hyperglycemia, guys, high levels of glucose. That's the theme for all this. I'd put that in the middle of the Venn diagram. Excuse me, which statement best differentiates type 1 from type 2 diabetes? I'll give you guys a second to answer. All right. If you guys said number 3, you were correct. Type 1 diabetes requires exogenous, requires outside insulin to live, whereas type 2 can sometimes be managed with oral medications or other modalities. So blood sugar management, kind of continuing. Most people, it goes to this chart is a good kind of look at this, and this kind of applies to type 1 or type 2. Medication, obviously more important in type 1, but exercise, you got to monitor the blood glucose, balance nutrition, and like really keeping track of carbohydrates, the sugars. The carbohydrate is just, again, nutrition wise, is a name for a family of all the sugars. There are polysaccharides and monosaccharides, and then you can break it down into cane, milk, and all the different types of sugars. But carbs is kind of your overarching term to talk about sugar. So, how do we diagnose diabetes? Obviously, we're going to have symptoms. Usually the three Ps are involved. And then a plasma glucose is usually equal to or greater than 200. And their glucose is measured in milligrams per deciliter, but that's not that relevant. I bet I could stop most nurses and ask them, how is blood glucose measured and like what measurement is it in? And they probably wouldn't know. And that's okay, because this one, thankfully, is standard across the world. If someone says my blood sugar is 200 in United States, if someone says that same statement in anywhere in Europe or somewhere else, it's the same. It's milligrams per deciliter. But they'll do like a fasting glucose greater than 126. And so our blood glucose should be dropping lower than that when we're in between meals, basically. Excuse me. They'll also do what's called a 2-hour like post-low glucose test. Like post-low means they'll give glucose and let it rise, and then within 2 hours, our body should be able to compensate. And if it hasn't, then that might equal that. And then another kind of big standard for diagnosing, if you want to kind of put a star on, kind of the most talked about or utilized one, is hemoglobin A1C. If it's greater than 6.5%, then that's typically talking about uh, equal to diabetes, basically. So, what a hemoglobin A1C is kind of measuring a what would be the word, a report card of your blood glucose levels over a 2 to 3 month period, basically because the way glucose travels sometimes is on a red blood cell to get to where it needs to go and then goes into other cells after that. And because of that, red blood cells live about 2 to 3 months. So when we checking A1C, hemoglobin A1C, we're looking at the hemoglobin and seeing the like percentage factor of glucose carrying basically over that period, because that's how long red blood cells live. And that's why we can get an accurate idea of what someone's blood glucose has been running over that 2 to 3 month time period. So it's a very strong test and a very big standard test as far as diagnosing diabetes. So over 6.5 is kind of considered you are diabetic, whether you want to admit it or not, and we need to do things to correct that, basically. This is a chart that kind of shows it. Again, it shows like test scores, the A1C, and then your mean, like your average blood glucose, and the glucose itself. Excuse me. So this is more like this is a chart not talking about diagnosing as much as it is about like where people want glucose control. So if you're diagnosed diabetic and your A1C um yeah, again, the chart's not an indicator for, let me reword that. The chart is not an indicator for diagnosing diabetes. This chart is just showing you kind of like how an endocrinologist or somebody would like process and think about someone's control. So if someone's been diagnosed with diabetes, they're probably someone that is had, if your A1C is kind of, if you did an A1C right now and your A1C is sitting anywhere around like, I think it's 5.8 to like 6.4, maybe it's 5.5 to 6.4. I can't remember exactly, but if your hemoglobin A1C is sitting in that 5.5 to 6.5 range right now, you're considered pre-diabetic, which is like, watch yourself. You're eating too much sugar. You need to change your diet, exercise, that sort of stuff. Make lifestyle modifications now. If it's more than 6.5, then you're considered you have diabetes and we have to deal with it. But this chart is just basically talking about if someone is diagnosed with that, where they're shooting their target. So your target is definitely less than 8 if you can. If you can keep your A1C around 6, then you're like excellent control. Anything higher than 8, you're kind of falling into the territory of like, we need to take medicine, we need to change our medicine, we need to do different things, basically, is kind of how you would look at that. So glucose monitoring, we have easy ability to self-monitor with test strips. And the frequency someone monitors their glucose can depend on their doctor's recommendations. Some people don't monitor enough. Some people have enough control that it's just monitoring it daily. But there are other people that would go back to that AC and HS. Um, again, before meals, an hour of sleep. So 4 times a day, basically, if they were getting insulin therapy, they would need to check it. And the thing for us in healthcare is that uh, um, for us in healthcare is that when it comes to insulin and diabetes and glucose monitoring, is that the rule of thumb, this is not a need to know necessarily for the test, but I would say it's pretty hardcore. Nice to know. The rule of thumb too is that you have to, you can't really confidently administer insulin or medications that are going to lower someone's blood sugar if you don't know what their blood sugar is. And that's why too, you'll see in the hospital, we'll check people's blood sugar all the time. And people are like, I only take a pill for this. I don't check it at home like ever, or I don't check it, 4 times a day. And you're like, well, in the hospital, stress and whatever's going on could cause elevated blood glucose levels. So we have to check it. But you have to, don't ever administer insulin without knowing what someone's blood sugar is. That's just a recipe for absolute disaster. Because that's the biggest risk factor. I think we have a slide about that. But the biggest risk factor with any of these medications about lowering blood sugar is obviously lowering too much. That's a big thing. Um, We also have UAs that can detect ketones, which again, ketones are part of the acidosis that's risky for diabetes. And it's just these are acid components that are from fat being broken down because it houses a lot of glucose. Yeah. And again, like I said, glucose management in the hospital, we have test strips everywhere that we can do the pin prick on the finger, test the blood. Um, Most of the time, the book and everything's going to teach you that you need to make sure and you would prick someone's finger and then a drop of blood would show up and then you'd want to wipe away that first drop and then just do a little squeeze and let the second drop hit the test strip. The rule of thumb, the thought for that is that there's oil on our skin, there's bacteria on our skin naturally, and also some of the alcohol wipe residue from you wiping their finger all can have somewhat of an effect on glucose readings. And so to get the most accurate, you want to kind of wipe away that first drop. And that's why they do that. So a patient has type 1 diabetes and reports nausea, excessive thirst, deep and labored breathing with fruity breath. What condition does the nurse suspect? That's right. If you guess number 2, you're correct. That's a tall tale sign of DK. DK. And because they're type 1 diabetics, you know that that's more at risk. So education for patient for self-administration of insulin. So there's some things to kind of note here. It's okay to keep insulin at room temperature. I can't talk. It's okay to keep insulin at room temperature. If you're going to keep insulin for long periods of time, you need to store it in a fridge. Do not randomly rotate sites, which means don't just pick a place to inject and kind of guess again the next day. Have a chart or do a counterclockwise rotation on your stomach on the fat tissue for injections. Insulin is an injection that needs to be absorbed into fat. So it's a subcutaneous injection. So typically the big area I'll show you in a second is around the stomach, around the belly button, but you can do other areas that have fat in the leg, perhaps back of the arm is somewhat common. And the needle angle is based on the patient's size. Typically, you can go 90 degrees. Sometimes textbooks will tell you 45 degrees. And make sure the needles are, you have a way to dispose of their needles, that they have puncture resistant devices. So like safe needle poke devices, safety mechanisms, that sort of thing. And then other things for them educating is they should stay hydrated. And with insulin administration, we're always kind of worried that we accidentally skip a meal and they drop their sugar off the map and become hypoglycemic. So they need to keep sugar-free snacks as well as regular snacks around their house just in case there's hypoglycemia. So locations, again, back of the arms, technically buttocks, thighs. The most common is probably going to be back of the arm, or self-administration is probably around the abdomen, and say not randomly rotate sites. Like if I did the left lower quadrant, I'd go like clockwise or something. The next time I do an injection, I do the right, and then so on and so forth. The reason we want to rotate sites is that constant needle and injection to one site can cause tissue damage and scar tissue to build up in that site. And that's going to not only be probably a little bit painful and annoying and risk for infection, but it's also just going to cause delayed absorption of that insulin at that same site if we have something like that develop. So acute complications of diabetes. These are the kind of the big 3. We already mentioned DKA, and I've already mentioned hypoglycemia. That's probably your most common thing that's going to happen with diabetes is hypoglycemia, just because our body's ability to homeostatically control our diabetes level is somewhat out of whack here. And so especially if we're treating it with medications, you got to think that it's possible they can let it. So the definition of hypoglycemia is a blood glucose that's less than 70 milligrams per deciliter. This is kind of more common with geriatrics and much more like risky. And then how do we treat that? And then we'll talk about DKA, and then a syndrome called hyperglycemic hyperosmolar syndrome, HHS, much easier to say, is also a risk factor. So there's also, when you're talking about glucose monitoring, mentioning that glucose glucometers can read low or high sometimes. If it's too low, it'll just say low. If it's too high, it's too high. Most glucose monitors, like handheld ones like this, will uh like the one that's showing the picture or the ones in the hospital will, I think it's 500 or is it 600? I'm just blank now. It's either 500. I'm pretty sure it's 500 milligrams per deciliter. I think it's a blood glucose of 500. They'll after that they'll just say high. Pretty sure. And if it's low, I think it's that one's kind of scary because I've seen glucoses read at like 23, 25. And technically low is under 70. So if someone's reading low on a glucose, that's either and they're awake and responding normally, that's probably a false negative or a false positive, or something's wrong with a glucometer or something. You got to try that one again. If they're reading low and they're symptomatic, lethargic, and not really responding appropriately, it's probably really low, and you should initiate emergency procedures. So remember, though, that's why I say if you see low or high, look at the patient, their symptoms. I always like to tell nurses and nursing students that you can't just treat a number. Like you can't just go by a number. You have to take the whole patient into account. So don't ever just treat just a blood pressure or just a glucose. You got to look at the patient, see what symptoms they're having. And that's why it's important to know these kind of symptoms and that sort of thing. So and the reason, again, we wipe away that first drop is just possible contamination from tissue fluid or bacteria, residual alcohol left from the wipe, that sort of stuff. So it's just good to wipe away the first drop because of that. So signs of hypoglycemia. This is a nice chart. But again, it's less than 70 milligrams per deciliter in adults. Again, what's going to cause it? Too much insulin, too much other diabetic medications, skipping meals. Diabetics can be prone to hypoglycemia just because their control is so irregular and they have issues. Some of the other reasons we can suffer from low sugar, even if we're not diabetic, just from excessive like anorexia or not eating. Some medications can cause anorexia and not make us feel like that. Alcohol consumption. So we can be hypoglycemic without diabetes. Typically, our body does pretty well by the regulatory systems. But how's someone going to feel if they have hypoglycemia? Their first earlier signs, like so, when it depends on the patient. Sometimes I've seen patients that have really irregular regulation of their glucose that have had a blood sugar like 55, 60 and not really had any symptoms. But I've also seen people that have had a blood sugar right at 70 or 75, 80, technically above the considered low, and had symptoms. So it is variable on the patient. But that early stage, if someone was around a 70 mark, they're going to be hungry. There should be. You're going to feel fatigued, shaky, sweaty, and pale skin. So think shaky, sweaty, and pale skin is like the most common, I'd say. Shaky, sweaty, pale skin, maybe some dizziness and a headache. And then if the blood sugar is really low, you're going to see like confusion, slurred speech, blurred vision, up to fainting or seizures or coma, like all the way down to the bad death. So 15-15 rule basically says like what's our nursing actions involved here is test blood glucose first, obviously. And if it's low and they are awake, talking, they're in those early stages, we're going to give them 15 grams of fast acting carbs. So sweets, soda, orange juice, something with a decent amount of carbs in it. We're going to wait 15 minutes to let that have an effect. And then we're going to repeat. And then we rinse and repeat that, basically, that kind of methodology of 15-15 rule until their blood sugar shows more than 70. We can do a glucagon injection. Glucagon, the hormone, can be made synthetically into an emergency IM injection. It's always going to be IN. So they're showing angle in the thigh or buttocks because it's an IM injection. We can also give, if you're in a hospital setting, you can give an IV syringe of dextrose, 50%. Usually it comes in an ampule that you get out of a crash cart. They call it an amp of D50. And this stuff is tough. The reason it's tough, if you've ever seen it, is that it's 50% dextrose. It looks like syrup, basically, and you're trying to push that in someone's IV. So if someone doesn't have a very good IV, a small bore, like a 22 gauge, or something like that, like you can kind of for sure that IV is going to blow trying to push that because it's so much pressure trying to push that through a vein. So bigger IV is better for that, but that's what you could do in the hospital setting for emergency low sugars. So just make sure you're listening to me. What patient has diabetes experience shakiness, confusion, sweating? What is the nurse's priority action? What are we going to do as a nurse? Again, there may be more than one right answer. This how NCLEX does it, right? What's the most correct answer? What can you do right now? If you answer number one, you're correct. That's that 15-15 rule. They have hypoglycemia. Now, it's not listed here, but would you want to check the sugar? Yeah. You'd want to kind of know where their sugar's at. Is it drastically low? What are we talking about here? But that's not one of the listed options. Calling the healthcare provider doesn't do anything that you can't already do. Every facility has hypoglycemic protocols, which tell you exactly letter to letter, task to task, what to do. And typically they all start with, if they're awake, talking, and can swallow, give them something that's got sugar in it. That's usually where they all start. Nurses educating a patient with newly diagnosed type 2 diabetes about lifestyle modifications. Which statement by the patient requires further teaching? So remember these questions, because these questions are like, I'm looking for the wrong thing about this condition. The patient said the wrong thing means I need to re-educate or educate them further. All right. If you, oops, answer number 3, you're correct. This requires further education. So they need to do all the things. They need to take their medication. They need to stop sitting on the couch or whatever. I'm just joking about what they do. They need to get off the couch. They need to change their diet. They have to do other things too. Just taking medication is not going to be enough once you're at the point of needing medication for type 2 diabetes. It's not going to be. Everything else is consistent with the things you'd want. Regular exercise, fiber and whole grains, less carbs. I should always monitor my blood sugar, even if I feel fine. And then this is like hypoglycemia, kind of like protocol options, like what people would do. These are not necessarily a memorization, but you can see like critical hypoglycemia is at less than 50, and you can see where it gets really intense. So is the patient able to follow commands? Yes. Can they take stuff by mouth? Yes. Okay. Give them glucose gel. It's a little gel that's sugary and tastes kind of sweet, but look, it's kind of gross. And it can be up to 2 tubes, like they're each 15 grams. And then in 10, 15 minutes, we'll check sugar again, make sure it's peaking. If they can't take PO, we're looking for IV access. No, then we go to glucagon, right? Because they can go IM. If yes, IV access, we can administer dextrose 25 grams IV within 10 minutes. And that 25 grams is usually the 50%, the AMPA D50. And then obviously you're always notifying the provider. And with the same, kind of very much the same thing here with the less than 70 but higher than 50. So this is just a nice chart that you would find like on the back of someone's ID badge. It's good. This is not necessarily need to know, but just think first for you guys. If I see hypoglycemia, I want to know what the sugar is. And depending on what it is, and are they awake and talking, I can give them oral glucose some way, food or glucose gel. If it's not, then I have to go to the other options, which is glucagon or IV dextrose, and I'm going to be calling somebody for sure. So diabetic ketoacidosis, onset usually could go for half the day. Um, Basically, what's the symptoms going to feel like? They're going to have that juicy fruit gum smelling breath, fruity breath because of the high sugar. Kussmaul respirations. Kussmaul respirations are that, again, like that force. It's like forced hyperventilation because your body is trying to compensate. Your body basically forces hyperventilation to try to or forces ventilation to try to basically blow off CO2 and correct the acidosis. They're going to be thirsty, dehydrated, heart rate's up, high blood sugar. This could be anywhere from 240 or above. I mean, it can be. Again, less typical. It's usually the sugar gets higher and we're going to get in the DK. They're going to have hyperkalemia because the kidneys are getting rid of a lot of water and losing sodium and retaining potassium with that polyuria. So what do they need? They need insulin, they need hydration, and they might need electrolyte balance, electrolyte replacement. And some more about DK. This is more common in type 1 diabetes, but this can happen in type 2 for sure. Don't rule that out. It can. But what's going to happen? They're going to have high blood sugar, hyperglycemia. They're going to have metabolic acidosis. So ABGs are going to be reading that pH, acidosis. They're going to have a bunch of glucose in the urine. They're going to have ketones in their urine. They're going to have ketones in their blood. What's the risk? Just inadequate medication and insulin administration. If they're a diabetic, especially type 1 with a concurrent infection or other illness, illness and infections stress our body out. You have to think that. So anything that stresses our body out is going to exacerbate any underlying conditions we already have. And then trauma or injury can make this worse for type 1 diabetic. Again, kind of that same similar as illness, stressing the body out. So kind of with this too, they're going to have confusion, feeling tired or faint, polyuria, dyspnea, thirst, dyspnea, polydyspnea, polyphagia, increased hunger, blurred vision. So think blurred vision, confusion, the 3 Ps basically. So DKA treatment, what are we going to do for this person? Well, I mean, first you always got to think ABCs, airway, breathing, circulation. But if they're awake and talking, we're going to make sure we're doing fluids to try to replace the fluid they're losing and try to flush out glucose that's in pretty severe. We can give insulin even intravenous if it's severe enough DKA. You'll see that comment. That patient's going to have to be in an ICU setting and closely monitored because what do you think insulin IV is putting them at risk for, right? Going the other way, hypoglycemia. And then we obviously have to monitor potassium levels. It's typically, again, that they'll have hyperkalemia with DKA just because of the polyuria and the loss of sodium and ends up raising potassium retention. So frequent labs, blood glucose checks, making sure we educate them. And we're kind of looking at an ABG probably for looking at acid bases, acid base imbalance. And with the potassium, sometimes too, it's just watching it. So if you're worried about someone's potassium, you're gonna put them on cardiac monitor. So this is why you see DKA patient. They probably might have to have IV insulin, decent amount of fluids, cardiac monitor. So this is like tends to be an ICU patient until we can correct their DKA. And typically, as their DKA corrects and we lower their sugar and we kind of correct the ketones and flush it all out, that the potassium tends to correct itself. Acidosis tends to correct itself. So yeah, IV fluids. Insulin drip, again, the biggest risk for giving them IV fluids, insulin drip, any of that sort of stuff. We know the risk with the potassium is cardiac arrhythmias, but IV fluids or insulin drip, the biggest risk is causing hypoglycemia. We're throwing them the other way, so it's just something to always keep in mind. That's always kind of the balance. So preventing diabetic ketoacidosis, sick day rules. So sick day rules, this is a need to know. Sick day rules is talking about if a patient with diabetes is sick, if they have a bad day and they have the flu or whatever, like what do they have to do? They have to take their insulin as usual. They could do this. They have home tests for this, or we could do this at the doctor's office or clinic. But testing blood for ketones or sugar, so glucosuria or ketonuria, then it's like, oh, we're getting into a decay state. Take insulin as needed. If they have PRN insulin, they might need to take it. They obviously need to check their sugar. Plenty of hydration. Any symptoms that start with the 3Ps and other confusion, fatigue, they need to get that reported sooner rather than later. So we're trying to prevent dehydration, continue eating and regulation, avoid exertion, really frequent blood glucose checks, check ketones and glucosuria, give insulin when it's supposed to be scheduled. So the reminder for you guys, the need to know for you guys for teaching patients on a sick day is like they shouldn't change how they take their insulin. They should be more proactive monitoring their sugars, more proactive drinking liquids, that sort of stuff. But they shouldn't skip meals. They shouldn't skip insulin. So we got to select all apply here. So a nurse is educating a newly diagnosed type 1 diabetic patient on sick day management. The need to know we just talked about, which of the following statements indicates correct understanding. So you need to pick all the questions that exhibit that the patient understands. So the incorrect answers would be stuff that needs further teaching, that the patient doesn't understand what to do on a sick day. All right, I know it takes a minute to answer those, so I'll give you a sec. All right, let's reveal the correct answers. So correct answers are 1, 3, 4, and 5. So just continue taking my insulin, even if I'm not eating that much. I need to check my blood sugar at least every 3 to 4 hours. So more frequent blood sugar checks. If I have ketones in urine and my blood sugar is high, I should drink more water and take a rapid acting insulin as directed my provider. So yeah, so if the provider's directed them to have some PRN rapid active insulin, that would be what they would do. Yeah, if I can't keep fluids down because I got a terrible stomach bug and it's coming out the front end and my blood sugar keeps going up, then I need to go to the hospital. So the other answers were if I should stop checking my blood sugar. No. If my blood sugar is high, I should skip my long acting insulin to avoid hypoglycemia. That doesn't even make any sense. So those are pretty easy. Some things to kind of think about towards the end here. So sick, sugar, insulin, carbs, ketones. So just another little acronym to help remember this sick day stuff. Because again, the sick day I'd say is need to know because it's patient education. Patient education always comes up on the NCLEX. So sugar, check blood glucose levels frequently, even more frequently for children or pregnant women. Always continue to take the insulin. Make sure you do actually have enough carbs and drink enough fluids. So enough intake. And then ketones, you're checking blood and urine ketone levels. If they're on the rise, then I'm concerned. So in here, we have HHS. This is the hyperosmotic syndrome. And what could cause this? This is more common in type 2. So DKA is more common in the type 1 diabetic. This is more common in type 2 diabetes, much more common in elderly. This is a large huge hyperglycemia, huge amount, 600 to 1200 milligrams per deciliter. This causes a huge amount of osmotic diuresis. Usually not many ketones. This is a huge, that's why they don't really have the DKA as much. This is just huge, large sugar, and think huge amount of diuresis. So again, what's the problem going to be? Fluids, insulin management, and probably potassium, because I'm losing usually sodium and fluid and retaining potassium. So huge high blood glucose above 600, dry mouth, dry skin, extreme thirst, extreme urination, warm flush skin, but it's not sweaty. Could have a low grade fever just because of the response, confusion, vision loss, even hallucinations, that sort of stuff. So what's the difference here, basically? So you want to, this is need to know. You want to know the difference. You need to know the difference between DKA versus HHS, hyperglycemic hyperosmolar state, HHS. So DKA, more common in type 1, but it can be seen in type 2, more common in type 1. HHS, definitely more common in type 2, or you could see it maybe in previously undiagnosed, unrecognized diabetes, but that's kind of one difference, right? The other difference is DKA is much more ketone body production and whole body systematic acidosis. This is hours to days this develops, so it's pretty quick. DKA can be. The HHS is higher hyperglycemia, so really profound, 600 to 1200. And they're going to have the hyperosmolarity. They're going to have ketone production is going to be down. They're not going to have any metabolic acidosis. They're going to have just huge dumps of urine. This takes days or weeks, a little bit more gradual onset. And this usually has a higher mortality rate. That's the main differences. So need to know the differences between DK and HSS. So make sure to read the book. You need to know this. So just refreshing what we just talked about. Which symptom is more commonly associated with hyperosmolar hyperglycemic state rather than DK? So which one's more common in HHS than it is in DK? So if you answered number 2, you're right. The profound dehydration, fluid loss, and that's going to cause neurological changes. Kussmaul respirations is a DK symptom with the body trying to compensate. Free breath and metabolic acidosis, all DK. Last couple things to make a note of for diabetes complications. So these are pretty evident. Most of these you've heard of before, but these are going to be need to know in a sense. You got to have a general idea of this. Stroke, high blood pressure, diabetic retinopathy, diabetic nephropathy, diabetic neuropathy, all the opathies. A lot to do with nerve and nervous muscular interfunction. But basically, think injury. Diabetes causes injury to the eyes, injury to the kidneys, injury to the nerves, poor wound healing, and then it's going to be tied into, again, diabetic foot ulcers and poor wound healing kind of come together, and stroke and cardiovascular disease. So you can kind of shorthand this more to, because high blood pressure is going to be part of cardiovascular stroke more likely. So stroke, cardiovascular disease, complications or injuries to the eye, kidneys, or neurons, skin conditions, and poor wound healing. That's how I would summarize it, if that makes sense. This is still in the category of need to know. You got to have an idea of what the complications are. And then just show you some stuff, some eyes and some feet to show you kind of what's happening is that it messes the blood. The reason the eyes are affected so much with diabetes is that you have to think of it this way too. This is what I usually tell students with diabetes and high sugar. Think about the difference between like orange juice and syrup. right? Orange juice is a pretty liquid. You pour it, it fits in a glass. Syrup, you pour it, it's much more sluggish, right? Like it comes out, but slower. That's kind of it's not real, but that's realistic necessarily. But to give you in a really, now I'm hungry. To give you a really goofy analogy to understand diabetes and what it does to blood and blood vessels is that it's like the difference between orange juice and sugar. A blood is like orange juice, where it's a liquid mostly. It has some solid components in it, like proteins and cells, but it's still a liquid. If I'm full of sugar, it's like turning my blood in from orange juice to syrup. And it is still liquefied, right? But it's much thicker and slower to flow, and it's going to cause more issues, right? And so that's kind of what happens to the eye, is that the eye has really, really tiny blood vessels, and that effect is going to cause bleeding or broken blood vessels. So aneurysms, hemorrhage, broken blood vessels, abnormal formation of blood vessels as they try to get around and still feed tissues, but they can't because their flow is so sluggish. It really affects the smaller blood vessels. So the eye gets affected within a more glaucoma kind of state of blurred vision and trouble. Peripheral neuropathy, it affects the peripheral nerves by causing paresthesias, that numbness and tingling sensation, burning and shooting pain in the feet, hot and cold sensitivity, that sort of stuff. And foot ulcers, again, typically the feet are such a crux area for diabetic patients because they're not managing their hygiene well enough to keep up with that. And they have such poor wound healing that a small abrasion or irritation in the foot could turn into a lesion that turns into an ulceration of foot, which causes complete tissue necrosis, the gangrene, something like that. So, and then because of the high sugar amount, it's also, think about this, because of the high sugar amount of the blood, it's a perfect vector for bacteria to grow, right? What bacteria wouldn't love a very sweet, sugary environment? And then all the things that does the blood flow. We need blood flow to do the inflammation, to do the healing process. If our blood flow is sluggish because of diabetes and high sugar levels, then it's going to be sluggish for healing as well. And kind of towards the end here, foot care for people with diabetes. They got to wash their feet every day. Excuse me. Keep their feet soft. They can do lotion, but we don't want to put lotion in between their toes just because it's more risky for fungal. So they have a bigger risk for fungal or other infections. They need to inspect their feet. They never can walk barefoot indoors or outdoors. They got to wear socks or shoes inside. They can't walk barefoot anywhere. That sort of thing. Nurses teaching a newly diagnosed diabetic patient about foot care. Which statement indicates need for further teaching? So that would say, which statement is wrong about diabetic foot care? So if you answered this one, you're actually right. This is a little cheeky, tough one for sure. But they should infect their feet daily. They should always wear shoes, even in my house. You could say even this statement's not necessarily wrong. You could tell them, well, you could just wear socks, but just can't walk barefoot anywhere. I should cut my toenails straight across. That's the correct way to cut your toenails. If you didn't know, you don't cut them at a triangle or round them, you straight across. So I should use lotion between my toes to prevent dryness. You can use lotion on your feet to prevent dryness. That is helpful, but in between your toes, just because of the way your skin is and the hyper sugar areas of your blood, is just the more risk for fungal infections or causing other infections. So that is chapter 46 in a nutshell, the diabetes summary points. Know what diabetes is, know the difference between type 1 and type 2. When I say know what diabetes is, what cells is involved, what endocrine organ is involved, pancreas, alpha beta cells, what hormones are involved, insulin, glucagon. Type 1, type 2 diabetes differences. in that too. Know the differences between DKA and HHS. Think about complications and treatment for hypoglycemia. Think about teaching for educating patient about lifestyle choices and foot care, and then also think about the common complications of diabetes: stroke, high blood pressure, cardiovascular disease, uh, non-healing, slow healing wounds, ulcers, that kind of thing. All right. Well, thank you guys for watching, and I'll catch you guys in the next one.